For the next 35 minutes, I'm going to tell you what are the latest updates on the guidelines on the treatment of hyperlipidemia. So for my talk, I will divide it into 3 parts. First of all, I will update you on the latest changes in the recent guidelines. Then I will cover our treatment options of lipid-lowering therapies and the latest advances, and also address any safety concerns that you may have when you lower the LDL levels to low levels in your patients. So I think there's no doubt that we now recognize that there's a causal relationship between cholesterol and the risk of cardiovascular disease. So you can see we have a large body of evidence coming from prospective cohort studies, also from genetic studies using Mendelian randomization approach, and also data from randomized controlled trials showing this relationship between cholesterol levels and the risk of developing cardiovascular disease. So I'm just going to remind you on the clinical trial data that we have over the years. First of all, we have large number of statin trials, and you can see in this meta-analysis, there is a proportional reduction in your risk of having cardiovascular events proportional to the reduction in your LDL cholesterol level. So you can see this linear relationship, and I want you to remember this figure because it will come up again in subsequent slides as well. So in this meta-analysis of statin trials, it's been estimated that for every 1 millimole per liter reduction in LDL cholesterol, you see a 21 to 24% reduction in major coronary artery disease or cardiovascular events, and 12% reduction in overall mortality. So after the statin trials, we have the IMPROVE-IT study, which is looking at the combination of simvastatin with ezetimibe versus simvastatin therapy alone in the IMPROVE-IT study, looking at patients with acute coronary syndromes. So in the combination therapy group, the LDL level achieved was 1.4 millimoles per liter. In the simvastatin alone group, the achieved LDLs was 1.8 millimoles per liter during the trial. And this translates into roughly about 6% reduction in the relative risk with a hazard ratio of 0.936. So this is significant, and we see a reduction in the major, in the primary cardiovascular outcome in the IMPROVE-IT study. So if you plot the IMPROVE-IT study along the line of cholesterol reduction versus reduction in cardiovascular risk, you can see IMPROVE-IT falls along the line similar to the statin trials. So after the availability of ezetimibe, we now also have the PCSK9 inhibitors to treat patients with high LDL cholesterol. And both the alirocumab and evolocumab, we have cardiovascular outcome trials that have been completed and published. So for the FOURIER trial is looking at evolocumab in patients with stable cardiovascular disease. In the Odyssey trial is the use of alirocumab in patients with acute coronary syndrome. So you can see in both studies, these monoclonal antibodies are very effective in lowering LDL cholesterol. In the FOURIER trial, the LDL was reduced to 0.78 millimoles per liter. In the Odyssey trial, LDL was lowered to around about 1 millimoles per liter. And because there was a PEC titration allowed in the Odyssey trial, at the end of the study, the LDL achieved was around 1.4 millimoles per liter. So with this degree of LDL lowering, we see a significant reduction in the primary endpoint of MACE, which is cardiovascular death, myocardial infarction, or stroke. Hazard ratio 0.85, and this was statistically significant in the FOURIER trial. And similarly, in the Odyssey trial, hazard ratio was also 0.85, and this again was also statistically significant. So in this slide, I've basically summarized the IMPROVE-IT study as well as the Odyssey trial and the FOURIER trial. And you can see with further degree of LDL lowering when these drugs were added to statin therapy, we see a significant reduction in cardiovascular events in our patients in secondary prevention. So here again, similar diagram as before, degree of LDL lowered versus cardiovascular risk and cardiovascular events. So back in the 1990s, when statins first became available, LDL levels around about 4 or higher, we can push down LDL relatively significantly. So 21% relative risk reduction translates to about 1 millimole reduction in LDL. And when we have high intensity statin available, we see a further reduction in cardiovascular risk around about 16%. And when we added Desitrol or further added PCSK9 inhibitors, we can push down the cardiovascular event rate further in our patients. So based on these recent data from the ezetimibe trials and the monoclonal antibodies trials, the guidelines have been updated and revised. And in 2019, the European Society of Cardiology and the European Atherosclerosis Society have updated the guidelines for the management of dyslipidemia. So in this slide, I put the 2019 guidelines on this side and the older version 2016 on this side. And the red box basically cover the main changes in the new updated guidelines. So patients are divided according to their cardiovascular risk. So patients at very high cardiovascular risk are those who have documented atherosclerotic cardiovascular disease, either clinical or unequivocal on imaging. And in this new guideline, they have further defined what's meant by unequivocal atherosclerotic disease on imaging. So these are patients who have significant plaques on either coronary angiogram or CT scan with multivessel disease with 2 major epicardial arteries having greater than 50% stenosis, or they have significant plaques on carotid ultrasound. Patients with diabetes with target organ damage or at least 3 major risk factors or early onset type 1 diabetes of long duration greater than 20 years are also considered to have very high cardiovascular risk. A new category that's been added to the very high risk category is patients with familial hypercholesterolemia. So average patients with atherosclerotic cardiovascular disease or they have another major risk factors are also considered very high risk. Categories that have remained unchanged are those with severe CKD with eGFR less than 30 mils, or those who have a calculated score greater than 10% for 10-year risk of fatal cardiovascular disease. Now the score is the sort of European version of the Framingham risk score, and this is based on data generated from European cohort data sets. Now for patients considered to high cardiovascular risk, these are patients with markedly elevated single risk factors, for example, a high LDL greater than 4.9 millimoles per liter, or high blood pressure greater than 180 over 110 millimeters mercury. Patients with FH without other major risk factors are now considered patients with high risk. Patients with diabetes without target organ damage, but have diabetes duration greater than 10 years or another additional risk factors are now put in the high risk category. Patients with moderate CKD or calculated score greater than 5% but less than 10% are also in the high risk group. Now for moderate risk group, young patients with type 1 diabetes less than 35 years of age or type 2 diabetes less than 50 years of age with diabetes duration less than 10 years and no other risk factors are now considered to have moderate risk. Those with low risk are those with a score less than 1% for 10-year risk. So this slide basically summarizes the different cardiovascular risk categories in the latest European guidelines. So the very high-risk patients are those with documented ASCVD, either clinical or by imaging. Patients with type 2 diabetes with target organ damage or 3 major risk factors, or early onset type 1 with long duration of disease. FH patients with atherosclerotic cardiovascular disease or another major risk factors, very high risk. Patients with eGFR less than 30 and a score risk greater than 10%. Now for the high-risk patients, if you have diabetes, no organ damage, but diabetes duration greater than 10 years, or you have another additional risk factor, FH patients with no major risk factors, CKD, eGFR between 30 to 59, and those with a score risk between 5% and 10%, these are classified as high risk. Moderate risk, young patients with type 1 diabetes less than 35 years, type 2 less than 50 years, DM duration less than 10 years without no other major risk factors, and the score is somewhere between 1 and 5%, these are moderate risk. So when you see a patient, you try and classify them and see which risk categories they belong to, and then you decide what LDL target you want to reach in your patient. So this is the LDL targets back in the 2016 guidelines, and this is the latest LDL goals in the 2019 guidelines. So you can see in the very high-risk patients, we've pushed the LDL target from less than 1.8 to less than 1.4 millimoles per liter. Patients in the high-risk group down from 2.6 to 1.8 millimoles per liter. Patients with moderate risk, less than 3 to less than 2.6 millimoles per liter. And the only group where the LDL target has remained unchanged is in the low-risk group, less than 3 millimoles per liter. So the latest guideline recommend more intensive reduction of LDL cholesterol across basically almost all the cardiovascular risk categories. So as you can see, the higher your cardiovascular risk, the more aggressive we are in lowering the LDL cholesterol. So in your very high risk group, we want to get the LDL down to 1.4 millimoles per liter if possible. And this is based on the recent data from the Improve It trial and also from the Odyssey and the Fourier trials in making these recommendations. So how do we get the LDL down to the levels that you want in your patients when you see them? So what are our options beyond statin therapy? So this is the treatment algorithm in the latest European guidelines. So when you see a patient, you want to do a cardiovascular risk assessment. You see whether you want to do any further cardiovascular imaging as well. Once you've defined the cardiovascular risk in your patient, then you want to see, is there any indication for drug therapy on top of lifestyle modification? If drug treatment is required, first-line treatment is high-potency statin at the highest recommended dose or tolerable dose in your patient. Once you've started your high-potency statin, you want to see whether you can reach your LDL cholesterol goal. So if your LDL goal is reached, you can follow up your patient annually or more frequently if indicated. If you do not reach your LDL cholesterol goal, then the second-line therapy is to add ezetimibe. Once you have on a combination of statin and ezetimibe, if you reach your LDL goal, that's good. If not, then for third-line therapy, currently it's recommended to consider a PCSK9 inhibitor. So in your very high-risk patients, if this is for secondary prevention or for primary prevention in FH patients who already have another major risk factor, it's recommended that you add a PCSK9 inhibitor. Now for primary prevention at patients with very high risk, but without familial hypercholesterolemia, then you can either consider adding a PCSK9 inhibitor or not, depending on your clinical judgment. So after statins, the second-line therapy we would suggest nowadays is to add ezetimibe. It's a cholesterol absorption inhibitor, and it inhibits intestinal uptake of dietary and biliary cholesterol in the intestine by interacting with the Niemann-Pick C1-like protein 1. By inhibiting cholesterol absorption, ezetimibe reduces the amount of cholesterol delivered to the liver and thereby upregulates hepatic LDL receptor expression and increases clearance of LDL from the circulation. So if you use ezetimibe as a monotherapy, you can reduce LDL by around about 15 to 20%. If you add ezetimibe to statin therapy, you can further reduce this LDL levels by up to 20% with combination therapy. And ezetimibe is a very well tolerated drug. So this is just a clinical trial data showing you the effectiveness of combination of atorvastatin with ezetimibe. So if you use combination therapy of ezetimibe, for example, with 40 milligrams of atorvastatin, you can lower LDL up to about 56%. And if you combine ezetimibe with high dose atorvastatin of 80 milligrams, you can lower LDL up to 60% in your subject. The third line therapy nowadays is the PCSK9 monoclonal antibodies. There are two currently available, which is alirocumab and evolocumab. They have to be given subcutaneously either once or twice monthly. They're very effective and they can lower LDL by up to 50 to 70%. It can also lower Lp(a) around about 15 to 30%. They are generally safe and well tolerated, and we don't see much injection site problems with these injectable therapies. They are currently approved for the treatment of established cardiovascular disease or in patients with very high cardiovascular risk, also in patients with familial hypercholesterolemia, or in subjects with statin intolerance. So this slide shows you what you can expect in terms of the degree, the magnitude of LDL lowering when you use these therapies. So if you use moderate intensity statin, you can lower LDL around about 30% roughly. If you then push it up to high intensity statin, we can lower LDL by about 50%. Combination of high intensity statin with ezetimibe, you can lower LDL up to 65%. If you use a PCSK9 inhibitor as a monotherapy, you can lower LDL roughly about 60%. And when you combine a PCSK9 inhibitor with high intensity statin, you can lower LDL by 75%. And if you use a free drug combination, PCSK9 inhibitor with high intensity statin as well as ezetimibe, we can now push LDL down to by about 85%. So we can now lower LDL cholesterol to unprecedented levels than previously. So if we look at I've shown you the new European guidelines. How does it compare with the American guidelines from the AHA and ACC, which were published in 2018? Both guidelines recommend achieving a risk-based percentage reductions of LDL cholesterol with statin therapy. In the European guidelines, they further recommended additional LDL lowering, and they are more liberal in supporting the use of both statin and non-statin therapies across a much broader patient groups. Whereas in the American guidelines, they can be considered to be more conservative for once. They reserve the addition of non-statin therapy to maximally tolerated statins only for select patient groups based on specific LDL thresholds. The American guidelines have also incorporated the consideration of cost in their recommendations, whereas in the European guidelines, they consider a more ideal setting with unlimited resources while making their recommendations. So the use of PCSK9 inhibitors were more liberal in the European guidelines. Now, I've only got one slide to talk about cost effectiveness because I'm not very good counting money. So in this study, what the authors have done is to compare the cost effectiveness of ezetimibe versus evolocumab as add-on therapy for secondary prevention of cardiovascular events in patients with type 2 diabetes. There are no head-to-head comparison comparing ezetimibe with PCSK9 inhibitors. So in this study, what the authors done is basically an indirect comparison, and they are able to do this because the rate of major adverse cardiovascular events in the control arms were comparable between the two studies. So in the IMPROVE-IT study, the rate of MACE in the control arms was about 6.5% per year. In the FOURIER trial is about 6.1% per year. So they are fairly similar. So in the FOURIER trial, the 1 year need to treat the NNT with evolocumab to avoid one major cardiovascular event was 104. In the IMPROVE-IT study, the 1 year NNT with ezetimibe was 124. So you can see, although evolocumab is more effective than ezetimibe for preventing one major cardiovascular event in patients with ASCVD and type 2 diabetes, the cost for preventing each MACE is significantly lower with ezetimibe, because you can see the NNT was 104 versus 124, but the cost of evolocumab was much higher than generic ezetimibe. The monoclonal antibodies have to be given by injection. We now have a new therapy which we can use in the future probably as third-line therapy, and this is bempedoic acid. This is an oral drug. It's a potent inhibitor of the enzyme ATP citrate lyase, which acts upstream to HMG-CoA reductase in the cholesterol synthesis pathway. So this is the ATP citrate lyase, and this is where HMG-CoA reductase acts in this cholesterol synthesis pathway. And by inhibiting this enzyme, bempedoic acid is able to reduce intracellular cholesterol production and therefore promotes increased LDL receptor expression in the liver and lowers LDL by increasing LDL particles clearance. So this drug has been approved either as a standalone drug or as a fixed-dose combination with ezetimibe by both the FDA and EMA earlier this year. So if this drug is used as a monotherapy, you can expect to lower LDL by up to 30%. It also lower high sensitivity CRP by up to 40%. Bempedoic acid is effective in lowering LDL cholesterol. Can it lower cardiovascular events and improve the cardiovascular prognosis of our patients? The cardiovascular outcome trial, the CLEAR outcome trial, is now ongoing with recruitment and is estimated to be completed in a couple of years' time. So this is a large, expected to run for 3.5 years, phase 3 clinical cardiovascular outcome trial. So we will have cardiovascular outcome data with this agent as well in a couple of years' time. So we now are able to lower LDL to very low levels in our patients. Do we have any safety concerns? We know there's a dose-response relationship between the magnitude of LDL lowering and the reduction in major cardiovascular risk. However, there is a long-standing controversy on whether very low total cholesterol and LDL cholesterol levels actually place individuals at a greater risk of having a cerebral hemorrhage. And there's also concern about achieving very low LDL cholesterol levels to the increased risk of diabetes and possibly even cancer. So let me just show you some epidemiological data first. So this is a large study of over 20,000 Chinese adults aged from 35 to 60 years, and they've been followed up for over 20 years. So if you look at this cohort that's been followed up for a very long period of time, and if you look at the baseline LDL levels and the risk of developing cardiovascular disease, you can again see a linear relationship. So the higher your LDL cholesterol, the higher is your hazard ratio. So if you have an LDL less than 40 milligram per deciliter, which is less than 1 millimoles per liter, you have the lowest cardiovascular risk. But if you look at the baseline LDL cholesterol levels and the development of cancer death during follow-up, we no longer see any relationship. You can see the line is pretty flat. So from this epidemiological data, it shows at least that very low LDL cholesterol levels does not increase the risk of dying from cancer. What about the risk of hemorrhagic stroke? So here is the LDL level at baseline. If we use the group with LDL between 70 to 99 milligrams per deciliter as the reference group, those subjects who have an LDL less than 70 milligrams per deciliter do have a significant increased risk of having a hemorrhagic stroke, and you can see the hazard ratio is 1.56 compared with those two patients or subjects with higher LDL level. If you then look at the interaction of blood pressure and LDL cholesterol, so patients with an LDL less than 70 milligrams per deciliter and have uncontrolled hypertension, they are the ones who have the high risk of having a cerebral hemorrhage. Those subjects with LDL less than 70 milligrams, but with well-controlled blood pressure, the risk of having a cerebral hemorrhage or hemorrhagic stroke is actually fairly similar to subjects with a higher LDL level. So if you have hypertension that's moderately well controlled but LDL less than 70 milligrams per deciliter, the hazard ratio is down by about half compared to those with uncontrolled hypertension. So from these epidemiological data, we can see that participants with baseline LDL less than 40 milligrams per deciliter had the lowest cardiovascular risk. There is an excess risk of hemorrhagic stroke in uncontrolled hypertensive patients with LDL less than 70 milligrams per deciliter. This excess risk of intracranial hemorrhage is associated with lower LDL cholesterol, was mainly seen in individuals with elevated blood pressure. So I think the message here is, yes, you can lower your LDL level in your patients as much as you want, but you also need to pay attention to that blood pressure control. For cancer risk, there's no association between lower LDL cholesterol levels and long-term risk of cancer death. So do we have more robust data than data coming from observational studies? So let's look at data coming from randomized controlled trials. So in the Odyssey outcome trials, there is a pre-specified analysis looking at the effect of alirocumab on stroke. So this is the Kaplan-Meier curve, and you can see the green line is any stroke, blue lines are ischemic stroke, and red lines are the hemorrhagic stroke. So let's look at the green line first. So this is the effect of alirocumab on any strokes. Here's the placebo arm. This is the alirocumab arm. So you can see there is a significant reduction in the risk of future stroke in patients randomized to the alirocumab arm. If we look at ischemic stroke, here's the placebo arm. Here's the alirocumab arm. And you can see alirocumab, by lowering LDL cholesterol, also reduces ischemic stroke. The red lines, this is hemorrhagic stroke, placebo, alirocumab arm. You can see there is no significant difference whether you are randomized to placebo or alirocumab. So there seems to be no increased risk of hemorrhagic stroke, even if we lower LDL down to about 1 millimoles per liter with PCSK9 inhibitors. So what the investigators have also done is they have divided into the alirocumab arm patients according to the LDL level achieved during the trial. So this is the LDL level less than 25 milligram per deciliter, 25 to less than 50, 50 to 70, and greater than 70. So in these different categories here, this is listed the number of subjects who have developed hemorrhagic stroke. And you can see the numbers are very small. And you can see there is no adverse dose response signal of hemorrhagic stroke with incrementally lower LDL cholesterol levels down to 0.6 millimoles per liter. So 25 milligram per deciliter is roughly about 0.6 millimoles per liter. So even pushing the LDL down to 0.6, we do not see a signal of increased risk of hemorrhagic stroke. What is the target of lowering LDL that might increase hemorrhagic stroke? So this is the Treat Stroke to Target trial, which was published in the New England Journal in January this year. And what this trial aims to do is to compare the target level of LDL 1.8 millimoles per liter versus a higher target level of 2.3 to 2.8 millimoles per liter, whether it can reduce the overall cardiovascular events in patients who had a prior ischemic stroke or TIA and also have evidence of atherosclerosis disease. And also in this study, they can also look at the risk of hemorrhagic stroke when you push the LDL down to 1.8 millimoles per liter. So 2,860 patients were enrolled and followed up for a median of 3.5 years. And these are the LDL levels. So this is the higher target group. So LDL aimed to be between 2.3 to 2.8 millimoles per liter. This is the lower target group, maintaining the LDL around about 1.8 millimoles per liter. So if we look at the primary outcome, the primary endpoint is a composite of ischemic stroke, myocardial infarction, urgent coronary or carotid revascularization, or cardiovascular death. You can see there's a significant reduction in primary outcome in the lower target group. Hazard ratio is 0.78, and this was statistically significant. So lowering your LDL down to 1.8 millimoles per liter reduces further events in patients who had a prior stroke in the past. So to get your patients to the lower target in the Treat Stroke to Target trial, the lower target group, about 24% require high-intensity statin and 34% required a combination of statin and ezetimibe. This is compared to the high target group where only about 9% required high-intensity statin and only 6% required a combination of statin and ezetimibe. Now, what about safety concern? Is there increased risk of hemorrhagic stroke? So here you can see intracranial hemorrhage, 18 in the lower target group, 13 in the higher target group. So the number are very small and there's no significant difference between the two groups. What about the onset of newly diagnosed diabetes? 103 in the lower target group, 82 in the high target group. Numerically higher in the lower target group, but this was not statistically significant. And you can see the hazard ratio, 95% confidence interval crosses 1. So far, data from the randomized controlled trials do not suggest a high risk of hemorrhagic stroke when you push the LDL levels at least down to 1.8 millimoles or even lower, but there may be a signal of an increased risk of diabetes. So meta-analysis have been performed to look at all the different randomized controlled trials with cholesterol-lowering therapy. So here in this part of the slide, this is looking at the association between incident diabetes and the achieved LDL levels between groups. This slide is actually looking at the risk of diabetes and the association with the percentage reduction of LDL cholesterol in the active arm. So it doesn't matter whether you're looking at the LDL levels that are achieved or looking at the percentage LDL reduction, you can see the line is pretty flat on both sides. So there's no significant association between the reduction in LDL cholesterol and incident diabetes when we use more intensive lipid-lowering therapy. So from this meta-analysis, there's no significant association between 1 millimoles per liter reduction in LDL cholesterol and the development of incident diabetes for more intensive lipid-lowering therapy. But if you look at individual drug class, then we do see there's a high risk of incident diabetes with statin therapy with a hazard ratio of 1.1. There's no association with incident diabetes when we look at the trials using PCSK9 inhibitors. So in conclusion, recent clinical trials have clearly indicated that the lower the achieved LDL cholesterol levels, the lower is the risk of future cardiovascular events. And at the moment, there's no lower limit for LDL values. And there's no J-curve effect that we can see. Studies of the clinical safety of these very low achieved LDL cholesterol levels have so far proved reassuring, although we do need monitoring for longer periods. The LDL cholesterol hypothesis is no longer a hypothesis. It's now established. We have a lot of data showing that increased LDL cholesterol levels are causally related to atherosclerotic cardiovascular disease, and that lowering LDL particles as much as possible reduces future cardiovascular events. And in the latest European guidelines, they have revised the cardiovascular risk stratification and the LDL cholesterol targets and incorporated newer non-statin therapies in the treatment algorithm. Thank you.